Here, welcome to Eduness channel. Welcome to the second episode of Drugs and Antidotes. In the last episode, we have seen 10 drugs, their mechanism of action and the mechanisms by which the antidotes neutralizes its effects. In this episode, we will explore the actions of some other medications that was not in the previous episode and the mechanisms by which the antidotes neutralizes it. So the first drug we see today is Methotrexate and the antidote of it is leucovorin or folinic acid. So let us see the action of methotrexate. Methotrexate is an antifolate antimetabolite medication that is used in chemotherapy and immune suppression. So it inhibits the enzyme dihydrofolate reductase that is needed for the folic acid synthesis inside the cell. So folic acid is needed for DNA and RNA synthesis, and it also inhibits the purine and thymidylate synthase, thereby inhibiting the DNA synthesis again. And it has autoimmune actions by inhibiting adenosine and guanine metabolism. So let us see how the antidote of methotrexate, leucovorin, acts. Leucovorin is a folate derivative, so it doesn't need reduction by the enzyme dihydrofolate reductase for its utilization. So there is readily available folic acid that can be used for DNA synthesis. So it promotes DNA synthesis. So the next drug we are going to see is organophosphates, and the antidote of organophosphates is atropine and pralidoxime. So let us see how organophosphorus acts in the body. Organophosphorus inhibits the enzyme acetylcholinesterase. Acetylcholinesterase is needed for the breakdown of neurotransmitter acetylcholine that is found in the central and peripheral nervous systems. So when acetylcholine gets accumulated in the body, it overstimulates the nicotinic and muscarinic receptors. So let us see it with the help of a picture in the next slide. So this is a neuronal junction, and this is a presynaptic nerve terminal, and this is a postsynaptic nerve terminal where muscarinic and nicotinic receptors are present. The space between the presynaptic and postsynaptic neurons is called synaptic cleft, and acetylcholine is stored as vesicles in the presynaptic nerve terminal, and it gets released into the synaptic cleft when stimulated. And this acetylcholine is degraded by the enzyme acetylcholinesterase into choline and acetate. So the organophosphorus inhibits the enzyme acetylcholinesterase so that the acetylcholine gets accumulated in the synaptic cleft, and it overstimulates the muscarinic as well as the nicotinic receptors. Acetylcholine is found in the central and peripheral nervous system, and stimulation of the nicotinic receptors at the neuromuscular junction can result in fasciculations and myoclonic jerks, and stimulation of the nicotinic receptors at the adrenal glands through the sympathetic nervous system can result in release of the catecholamines like noradrenaline and norepinephrine, and can result in hypertension, sweating and tachycardia. Stimulation of the muscarinic receptors at the sympathetic nervous system, for example in sweat glands, can result in increased sweating, and at the parasympathetic nervous system can act in the heart, resulting in decreased heart rate or bradycardia. And in the exocrine glands, it increases the secretion of the glands, and in the smooth muscles, it increases the smooth muscle contraction. For example, in GIT, it causes increased bowel motility, and in the respiratory system, it causes increased bronchial smooth muscle contraction. Now let us see the action of the antidotes atropine and pralidoxime. Atropine is a competitive antagonist at the muscarinic receptor sites. It binds and blocks these receptors. It inhibits the effects of acetylcholine at the muscarinic receptor sites. Now let us see pralidoxime. It mainly acts at the nicotinic receptor sites, and it is an acetylcholinesterase enzyme reactivator. So the pralidoxime get phosphorylated by the organophosphates instead of the enzyme, and acetylcholinesterase is available to degrade the neurotransmitter acetylcholine. Now let us see the next drug, anticholinergics. The antidote of anticholinergics is neostigmine. Now let us see the action of neostigmine. Neostigmine is an acetylcholinesterase inhibitor. So when acetylcholinesterase is inhibited, there is accumulation of acetylcholine in the neuronal junction so that it can bind to the muscarinic and nicotinic receptors. It is used in diseases like myasthenia gravis, which is an autoimmune disorder characterized by the damage of the acetylcholine receptors. It is also used in reversal of the neuromuscular blockade during the administration of anesthesia. So it overcomes the competitive inhibition of the non-depolarizing blocking drugs. Let us see the next drug, beta blockers, and the antidote is glucagon. So the beta blockers act by blocking the beta 1 receptors in the heart and results in decreased heart rate. The glucagon increases the heart rate by direct action on the SA node via GLP-1 receptor. It increases the myocardial contractility and AV conduction, and it bypasses the beta blockade. Let us see the next drug, calcium channel blockers, and the antidotes are calcium gluconate and high dose insulin therapy. So the calcium channel blockers prevent the calcium entry into the cell, and it results in vascular smooth muscle relaxation or vasodilation, decreased myocardial force generation or negative inotropy and contractility, decreased heart rate or negative chronotropy, and decreased conduction velocity mainly at the AV node. So the calcium channel blockers blocks the L-type calcium channels in the smooth muscles of the blood vessels, heart muscles or myocytes, and the cardiac nodal tissues. Now let us see how the antidote of calcium channel blockers, the calcium gluconate, works. It antagonizes the action of calcium channel blockers. It increases the level of extracellular calcium and competitively binds to the calcium channels. So it enhances the myocardial contractility and vasoconstriction of the blood vessels and increases the heart rate as well as the conduction velocity. So the calcium channel blockers reduces the insulin secretion, it creates tissue insulin resistance and interferes with the glucose catabolism leading to lactic acidemia and metabolic acidosis. High dose insulin administration is used in this scenario to reverse all of these derangements of metabolism. Insulin has a direct positive inotropic effect, meaning it increases the myocardial contractility. Let us see the next drug, calcium gluconate, and the antidote of calcium gluconate is magnesium sulfate. So magnesium sulfate acts as a calcium channel blocker and it depresses the function of smooth muscles, cardiac muscles and skeletal muscles. The next situation is carbon monoxide poisoning, and the antidote of carbon monoxide poisoning is hyperbaric oxygen therapy. So the carbon monoxide poisoning causes hypoxic ischemia. The carbon monoxide has high affinity towards hemoglobin and it binds to the hemoglobin to form carboxyhemoglobin and decreases the oxygen carrying capacity. It also activates guanylyl cyclase and increases the cyclic GMP, resulting in cerebral and peripheral vasculature, smooth muscle dilation, myocardial suppression, and central nervous system damage. So the half-life of carboxyhemoglobin is dependent upon the concentration of inspired oxygen. So it is approximately 4.5 hours on room air and it is approximately 90 minutes on normobaric 100% oxygen and 20 minutes on hyperbaric oxygen. So what happens when we administer hyperbaric oxygen? So it increases the amount of dissolved oxygen in the blood. It increases the rate of displacement of carbon monoxide from the hemoglobin. It also prevents neurological impairment. It also has other benefits like restoring the mitochondrial function, decreases the production of reactive oxygen species, and protection against cerebral edema and increased cerebrospinal fluid pressure. The next scenario is cyanide poisoning, and the antidote used in cyanide poisoning is hydroxycobalamin, sodium thiosulfate, and sodium nitrite. So what happens in cyanide poisoning? So there is cessation of the aerobic cell metabolism in cyanide poisoning. The cyanide binds to the ferric ions of the enzyme cytochrome oxidase. So cytochrome oxidase is an enzyme in the mitochondria of the cell. So the oxygen is unable to attach to the ferric ions and it halts the cellular respiration by blocking the reduction of oxygen to water and interferes with the ATP synthesis. So this is a schematic representation of cyanide binding to the ferric ions of the cytochrome so that oxygen is unable to attach to the cytochrome and interferes with the cellular respiration. Now let us see the action of antidotes in cyanide poisoning. The first one is sodium nitrate. So the nitric oxide from the sodium nitrate reacts with the ferrous ions in the hemoglobin to form methemoglobin. The cyanide preferentially binds to the methemoglobin, which releases the cyanide from the cytochrome oxidase. So thereby the cytochrome oxidase activity is restored. So now let us see the action of other antidote, sodium thiosulfate. So the cyanide is converted into thiocyanate by the enzyme rhodinase in our body and is excreted in urine. So the sodium thiosulfate is a sulfur donor for the enzyme rhodinase. So the function of rhodinase requires constant supply of sulfur. So the sulfur depletion can result in cyanide being accumulated in our body. So the sodium thiosulfate provides the sulfur so that the rhodinase enzyme activity is augmented and it enhances the endogenous cyanide detoxification capacity. Another drug used in cyanide poisoning is hydroxycobalamin. It has high affinity to cyanide. It binds to cyanide to form cyanocobalamin or vitamin B12 and is excreted in the urine. So the next scenario is lead poisoning, and the antidote used in lead poisoning is dimercaprol or succimer or DMSA and calcium disodium editate. So lead interferes with different cellular mechanisms. It affects almost all the organ systems and it inhibits the different enzymes in the body. For example, degradation of ribosomal RNA in the red blood cells, disruption of hemoglobin synthesis. It also acts competitively with calcium in several biological systems such as mitochondrial respiration and various nerve function. It also activates protein kinase C, resulting in neurotoxicity. Lead also alters the permeability of the blood-brain barrier. It affects the nucleic acids, DNA and RNA. It affects the cell membranes, interferes with various energy and transport systems, promotes generation of superoxide and hydrogen peroxide in human endothelial cells and vascular smooth muscle cells, which increases the blood pressure. Now let us see the antidotes of lead poisoning. The first one is dimercaprol. It is given parenterally. It's a chelating agent that binds to the lead and promotes elimination from the body. It is given in combination with the calcium disodium editate. The next antidote used in lead poisoning is succimer or 2,3-dimercaptosuccinic acid or DMSA. It is a water-soluble derivative of dimercaprol. It is given orally and it has replaced dimercaprol due to its broader therapeutic index and fewer side effects. So another drug used in lead poisoning is calcium disodium editate. Its chelation forms non-ionizing salt and is excreted in the urine. It can cause hypercalcemia, so it is a nephrotoxic, and it is able to chelate zinc, so it can cause convulsions, paralysis and encephalopathy. It is given after dimercaprol to prevent the acute effects like convulsions. So the next scenario is methanol poisoning, and the antidote used are fomepizole and ethanol. So methanol is metabolized by the enzyme hepatic alcohol dehydrogenase. So metabolism of methanol forms formaldehyde and formic acid. So these metabolites are bound to tetrahydrofolate and is converted into water and carbon dioxide. So the formaldehyde and formic acid are the toxic substances that can cause GIT disturbance, CNS depression, metabolic acidosis, retinal toxicity and basal ganglia toxicity. Now let us see the antidotes of methanol poisoning. The first one is fomepizole. It is a competitive inhibitor of alcohol dehydrogenase. It stops conversion of methanol to formate, the toxic compound, and it slows down the methanol metabolism. So the next one is ethanol. It is a competitive alcohol dehydrogenase substrate. So it competes with the methanol for alcohol dehydrogenase. Slowing down the metabolism helps to excrete the methanol through the urine. So thank you for watching the video. So as I always request, if you like the video, please like and subscribe the channel so that you will be getting notification when new videos are being uploaded. And see you with a new topic soon. Till then, bye.